It begins with a cough, a wheeze, or tightness of chest. Soon, shallow breathing is followed, making it difficult to take a gap of breath. These are common symptoms of obstructive and restrictive respiratory diseases. Respiratory diseases have been deemed as a worldwide health burden, attributed to its causes of severe illness and death worldwide. Around the world, a total of more than 534 million people are affected from respiratory diseases such as chronic obstructive pulmonary disease and asthma. Classified as conditions that are restrictive or obstructive to the normal functioning of the lungs, it induces respiratory impairments that can be mainly characterized by symptoms of dyspnea. Amongst the existing treatments targeted towards respiratory diseases, bronchodilators have been shown to be one of the basic medicines that are used to ameliorate and improve respiratory conditions such as COPD, asthma, varying allergic reactions, and other related conditions that can cause breathing problems. Mainly, bronchodilators are associated with the treatment for COPD and asthma patients. Physiologically, asthma arises from narrowing of the airways that allow air to move in and out of the lungs. As a result, accumulation of mucus, spazzing or swelling of the muscles that surround the airways can occur, leading to asthma and its symptoms. Holding similar symptoms and markers of breathing difficulties, the pathophysiology of COPD involves the inflammation and thickening of the airways in the lungs, where consequently the tissues where oxygen is exchanged becomes destroyed. Such occurrence decreases the flow of air in and out of the lungs, limiting the oxygen that can get into the body's tissues and correspondingly the ability to remove waste gas, carbon dioxide. As COPD gets worse, shortness of breath accordingly transpires. In these conditions, bronchodilators come into play by either 1. Reversing symptoms of asthma, or improve lung function in patients with chronic obstructive pulmonary disease, although there is often limited reversibility of airflow obstruction. Nevertheless, on a whole, treatment by bronchodilators are assistive for individuals who suffer from lower optimal airflow than the normal standard airflow, and aim to alleviate bronchial obstruction and airflow limitation, reduce hyperinflation, and improve emptying of the lungs and exercise performance. Mechanistically, bronchodilators function by inducing dilation of the airways, or bronchial tubes of the lungs, by relaxing the smooth muscles of the bronchiole and subsequently allowing users to have breathing difficulties to breathe with more ease. Altogether, the use of bronchodilators can help and serve benefit for patients with frequent exacerbations and severe airflow obstruction by reducing the airway resistance and elastic loading of the inspiratory muscles during exercise at constant work rate. In addition to this, bronchodilators act on peripheral airways through reducing air trapping and subsequently decreased lung volumes. The lower operating lung volume permits patients to fulfill the required alveolar ventilation during rest and exercise at a lower oxygen cost of breathing, in turn ameliorating symptoms and exercise capacities. Within the bronchodilator treatment, 3 classes are currently available. These are namely beta-adrenergic bronchodilators, anticholinergic bronchodilators, and xanthine derivatives. All classes of bronchodilators function on the same basis of dilating airways by relaxing the bronchial muscles. However, each class accomplishes this through varying approaches. Beta-adrenergic bronchodilators work by stimulating the beta-2 receptors on the smooth muscle cells, which is a G protein-coupled receptor that lines the airways. This induces activation of the beta-2 receptor and thus relaxes the smooth muscles of the airway, reducing air trapping and thus opening and dilating the bronchial airways. Anticholinergic bronchodilators target parasympathetic nervous system receptors in the airways, inhibiting their function. In particular, they target acetylcholine, a chemical that nerves utilize for communication within muscle cells. In respiratory conditions such as asthma, cholinergic nerves going through the lungs induce the narrowing of airways by stimulating the muscles surrounding the airways to contract. Anticholinergic bronchodilators counter this by blocking the effect of cholinergic nerves and acetylcholine on the airways and nasal passages, resulting in the reversal of bronchial secretions and constriction by the parasympathetic nervous system, and in turn inducing the muscles to relax and airways to dilate. Finally, xanthine derivatives suppress the response of the airways to stimuli, relaxing the smooth muscles in the walls of the airways. Unlike the other 2 classes, however, the exact mechanism of action has not yet been fully elucidated, though it is currently speculated that xanthine derivatives dilate the bronchi through inhibiting the action of phosphodiesterase enzymes, leading to an increased concentration of chemicals that dilate the bronchial airways. Altogether, these can be used individually or in combination. The combination of bronchodilators in many patients have not shown to provide any substantial improvement in lung function. Nevertheless, for patients who do need to be controlled by combinations of treatment, specialists have advised that two bronchodilators with varying mechanisms of action are incorporated. By doing so, lower doses of individual agents, a decrease in adverse effects, simplified medication regimens, as well as improved compliance may occur. Predominantly, combinations of beta-2 agonists with antimuscarinic agents have shown to amplify the relaxation of bronchial smooth muscles, deeming it as a beneficial approach. Unfortunately, however, there are currently no clear indications or guidance on when the combination of bronchodilators is required, and therefore the choice of agents for the treatment of patients depends significantly on the individual response, side effects, and availability. Commonly, therapy starts with an experimental choice of treatment, followed by the recording of the patient's response to the treatment, resembling a trial and error process. Apart from the three bronchodilator classes, bronchodilators can be further segregated into short-acting and long-acting treatment. Short-acting formulations open the airways very quickly and are thus applied for short-term relief from unexpected attacks of breathlessness or sudden and acute asthma symptoms. Starting within minutes after inhalation, this form of treatment typically lasts for 2 to 5 hours. Alternatively, long-acting bronchodilators do not work as quickly as the former and cannot treat acute or sudden symptoms. These are usually used alongside inhaled steroids and function to provide long-term control of breathlessness, showing effects for approximately 12 to 24 hours. Unlike short-acting beta-2 agonists, long-acting beta-2 agonists have shown to improve the mucociliary component of conditions such as COPD. Beta-2 agonists and anticholinergics are available in both short-acting and long-acting forms, while xanthine derivatives are, as of now, only available in the long-acting form. Amongst the classes of bronchodilator treatments, the most common one that has been used are beta-2 agonists due to their greater efficacy and lower rates of side effects. Some particular examples of short-acting beta-adrenergic bronchodilator treatments include albuterol, levobuterol, and epinephrine injections, while long-acting formulations include salmeterol and formoterol. The administration of bronchodilators is possible through inhalation or oral ingestion through pills or syrups, where generally inhaled bronchodilators are the primarily preferred option due to its seemingly higher efficacy to deposit the drug directly into the lungs bronchioles while having fewer side effects. Inhalation devices exist in all shapes and sizes, with the key aim of the delivery process being maximizing the amount of drug that reaches the bronchioles. This can be achieved by full exhalation of the patient, then full inhalation after the inhaler is placed in the mouth. After maximal inhalation, 10 seconds of no breathing is recommended to allow dissipation of the medicine into the lung space. The patient should then slowly exhale back to the normal breathing. Like any other medicine, however, bronchodilators carry both short and long-term adverse effects that are provoked by activation of the sympathetic system. The most common effects include trembling, coughing, nausea, nervousness, and sudden heart palpitations. Additionally, more severe effects include sudden constriction of the bronchial airways, hypokalemia, paradoxal bronchospasm, and in a few cases, myocardial infarction. Under such circumstances, a primary care physician should be contacted. Adverse side effects vary from patient to patient depending on the type of bronchodilator treatment taken, as well as the patient's health status and circumstances. As such, patients are advised to work with their healthcare provider to determine whether the benefits of bronchodilators outweigh the possible adverse effects that may arise for the individual. Risks that may induce harm or amplify side effects apply to patients who have the conditions below. Despite the fact that bronchodilators are considered as a mainstay of the current management of common respiratory conditions such as COPD and asthma, areas of grey still exist on certain aspects of the treatment, including the insufficient amount of evidence that has been found to support whether or not bronchodilator treatments can be used for asthmatic patients or not. Further, there is no distinct guidance elucidated for which class of bronchodilators should be considered first or what the optimum frequency for dosage is. Instead, a process of trial and error is currently followed, which illustrates the treatment to be flawed to an extent. These ambiguities regarding bronchodilators suggest that further research should be implemented to improve the treatment and its potency. Apart from improving the existing treatments we have today, the generation of new bronchodilator agents could be studied and further developed on. Numerous possibilities have emerged, including the development of nitric oxide compounds to be used as novel bronchodilators. However, difficulties exist in the targeting of nitric oxide to go to the lungs, as well as achieving a beneficial action with as little adverse effects as possible. In future times to come, however, developing our knowledge on bronchodilators may allow greater results and opportunities to arise for the medical industry, particularly for patients suffering from such relevant and common respiratory conditions.